All right, let's dive into a topic that you as pharmacists deal with all the time at the counter, heavy menstrual bleeding. We're going to break it all down in this practical guide. So, get this, about 30% of patients feel that their menstrual bleeding is excessive. That's huge. We're talking nearly 1 in 3 people. This makes heavy menstrual bleeding, or HMB, one of the most common issues you're going to help manage.
And that's the million-dollar question, right? It's not just about handing over a prescription. It's about giving that expert advice that can really improve someone's quality of life and, just as importantly, keep them safe. Okay, first things first. Let's make sure we're all talking about the same thing when we say HMB. The definition has actually changed over the years, and it's a really important shift in how we think about patient care. See, the key thing here is we've moved on from a rigid number, like, say, 80 milliliters of blood loss. Now the definition is all about the patient's actual experience. How is this bleeding really impacting their life? It's a much more patient-centered way to look at it. So when you see a prescription for an HMB therapy, these are the 3 big goals behind it. Number 1, obviously, is to make the patient feel better. But it's also about digging deeper to figure out why it's happening and tackling related issues like iron deficiency anemia, which can make people feel completely wiped out. And to get to that why, clinicians have this fantastic system called PALM-COIEN. Honestly, once you understand this framework, it makes it so much easier to see why a doctor chose a specific treatment. So it breaks everything down into 2 main buckets. The PALM side covers structural causes. Think of these as the hardware issues, things you can physically see, like fibroids or polyps. Then you have the COAN side, which is more like the software, functional or systemic problems, like a bleeding disorder or a hormone imbalance. And this distinction is key, because a structural problem might need surgery down the road, while a functional one is usually managed with meds. So let's get into those meds. We're going to look at the prescriptions you're going to see day in and day out. These are the first-line go-to options for managing HMB. The big split here is between hormonal and non-hormonal approaches. The hormonal options, like the pill or a hormonal IUS, work system-wide. They quiet down that whole hormonal conversation between the brain and the ovaries to keep the uterine lining thin. On the flip side, non-hormonal options like tranexamic acid or NSAIDs are all about local control. They work right in the uterus to manage bleeding without messing with hormones systemically. Which one gets chosen often comes down to what the patient wants and whether they also need contraception. Now, let's talk about just how effective some of these can be, because this number is pretty incredible. The levonorgestrel IUS can slash blood flow by up to 97% in the very first year. It's an absolute powerhouse. And here's why it's considered such a top-tier option. I mean, it's more effective than other medications. It doubles as long-term birth control. And get this, patient satisfaction is so high, it's right up there with surgical options. Plus, it's versatile enough to be used for HMB caused by fibroids and adenomyosis. It's a real workhorse. But, of course, first-line treatments don't work for everyone. So, what's Plan B? Let's talk about some of the other drugs you might see, which, often need a bit more in-depth counseling from you.
GnRH agonists are a great example. They are super effective. They basically put the ovaries on a temporary pause, which stops periods completely. But the trade-off is that they induce a temporary menopause, which means hot flashes and, more seriously, bone density loss. That's exactly why you'll see their use is limited to about 6 months, unless the patient is also getting add-back hormone therapy to protect their bones. Okay, I need everyone to listen up for this next part. This is an absolutely critical safety update about a drug that used to be a common choice for HMB caused by fibroids. The drug is ulipristal, which you might know as Fibristol, and the reason it was pulled from the Canadian market is chilling: risk of serious liver injury requiring liver transplant. This isn't just a potential side effect, it's a real, severe danger that makes this one of the most important things we need to be aware of in our practice right now. So if you ever come across a patient who is somehow still taking ulipristal, your counseling needs to be immediate and direct. They have to stop the medication right away. They need to call their doctor. And you need to let them know they'll need blood tests to check their liver function 2 to 4 weeks after they stop. This is a moment where you can make a critical, life-saving intervention. All right, let's switch gears and get into some quick, practical counseling pearls for the medications you'll dispense every single day. This is really where you get to shine. For NSAIDs like ibuprofen or naproxen, you gotta tell them timing is key. They work way better if you start them a day before the period is even expected to start. And of course, always with food. The big red flag to watch for is the interaction with SSRIs. That combination can seriously increase the risk of a GI bleed. Now for tranexamic acid. If you remember one single thing from today, please let it be this: the contraindication. This drug works by helping the blood to clot, so it is an absolute no-go for anyone with a history or risk of blood clots. We're talking DVT, pulmonary embolism, stroke, you name it. This is a non-negotiable safety check every single time.
And when you're counseling on oral progestogens, it's all about managing expectations. You'll want to give them a heads up about common side effects like bloating, mood swings, that kind of thing. A great little tip for micronized progesterone is to tell them to take it at bedtime, since it can make people drowsy. And, compared to combined hormonal contraceptives, they're just not as good at making cycles regular and predictable. With CHCs, the key is consistency. Same time every day is crucial for controlling that bleeding.
So, as we wrap this up, I want you to think about this. From the new patient-focused definition of HMB all the way to that critical safety alert on your Lipperstall, what's the one piece of information you'll take with you that's going to change how you talk to your very next patient? Because that's how we take what we've learned today and turn it into better care.